Good morning. This is Yvette Kelly with the Managed Care Technical Assistance Center, and I'd like to welcome you to today's guidance for OMH licensed housing providers in New York City during the COVID-19 State of Emergency webinar. Today I'm joined by some of my colleagues here at MCTAC, along with a number of our state partners who will walk us through some time-sensitive information related to the COVID-19 State of Emergency. Before we get started, I just want to review a few housekeeping items. The slides and recording will be made available and posted to our website shortly after today's presentation so that anyone who'd like to review this content at a later date will be able to do so. Today's presentation will also conclude with a question and answer period, and so we're asking participants to please submit your questions at any point during the webinar. You can do this by utilizing the chat box feature located on the right-hand side of your screen. If you could just submit your questions there, we'd appreciate it. Our state partners will do their best to address these questions in the time permitted. In the event that they're unable to get to all of the questions, they will be addressed later in an FAQ document. For any technical difficulties, please chat to our host, who should be able to assist you. And with that, I'm going to pass it over to our state partners to get started.
Great. Good morning, everybody. This is Moira Tashin. I'm the Associate Commissioner for Adult Services here at the Office of Mental Health. Thank you for joining our call. I also want to thank you for everything you're doing as you face your challenges, which I know are great right now. We recognize that. We know that you're working 24/7 plus. We know that you're working with short staff, high needs individuals, and people testing positive in your programs. We also know that you're working in situations where you don't necessarily have the equipment you need. So again, I want to thank you for that as I recognize your challenge. We also want you to know that we are trying to address those challenges as best we can. Your partnership. Thank you for your partnership. As you may know, we are moving to increase step-down capacity in our state hospitals to help the community hospitals, the Article 28 inpatient units, be able to move their individuals who are in their inpatient units into our state facilities or other appropriate placements so that their hospitals can be used for med-surg. We're going to continue to do that, and I'm certain we will have conversations with some of you for assistance to do that as we move into the next coming weeks. I want to start out with some good news, though, and that is that the executive order was issued about a half an hour ago for background checks and fingerprinting. We will be getting guidance out to you all by the end of today for that, so that was some good news that was brought to us today. I also want you to know that we are doing our best to get you some PPE, some masks, and equipment. We're looking to put a bulk order in, and we're including you in that bulk order. We'll have more information as the week progresses. So today, our presenters will be Dr. Flavio Casoy, who is our Medical Director for OMH Special Projects, Donna Bradbury, who's the Associate Commissioner for our Division of Integrated Community Services for Children and Families, Meredith Ray Labatt, I always say that wrong, Meredith, sorry about that, Deputy Director for the Division of Services for Children and Families, and Brett Hebner, the Director of Housing. Advance the slide. The topics that we're going to be covering today will be the information overall, infectious control, operations during the emergency, staffing, as well as clients with symptoms, maintaining continuity of operations and care, and program and state aid flexibility. At the end, we will certainly take your questions and help to provide as many answers on here as we can. The questions that we cannot answer because we've run out of time or we have to check further, we will be responding in an FAQ. I'd like to turn this over to Donna Bradbury, who will first discuss the children's residential programs. Donna?
Great. Thank you, Moira. Good morning, everybody, and thank you for being with us. And I want to echo what Moira said earlier about recognizing the challenges that you face during this crisis. And I also thank you very much for your efforts, and thank you for being with us on this WebEx. I want children's providers to be aware that the guidance that you're going to hear about during this presentation is applicable to all children's residential and site-based programs. We will be issuing guidance specific to children's mental health programs in the coming days. And in the meantime, the OMH guidance that's already been issued in terms of infection control is applicable to crisis residents, community residents, and residential treatment facilities. I do want to also make note that we realize that there are unique aspects to children's programming that pose special challenges during this crisis. In particular, we realize that discharges are dependent upon school placement, and we are working with state education to generate solutions to the problem which is at hand, which is that with districts being closed, I'm told that committees on special education are not meeting, and we need to understand that better with state ed and work together to generate solutions so that as children and youth are ready for discharge from your programs, they can be appropriately matched to school education programs outside of your residential program. Also, I'm addressing specifically programs now that provide both OCFS foster care residential and OMH residential on the same campus. We are currently working with licensing and council to understand the degree to which we may create some flexibility to commingle populations only if that becomes necessary from an infection control standpoint. So more to come on that. But I wanted you to be aware that we're working on those particular issues. With that, I'm going to hand it over to Dr. Kasoi.
All right, thank you, everyone. Hopefully you can hear me. I also want to echo Moira and Donna to thank you. You all really are the first responders, the shock troops, the front line of this absolute emergency, and you know, our clients, our patients desperately need you, and I really, really thank you from the bottom of my heart. You know, you're showing up every day, taking care of these folks who are often forgotten in our society. So, you know, you're real heroes. So just to talk a little bit about the nuts and bolts of the biology here. So COVID-19 is a virus that you know, is very infectious, similar to the common cold, but it also leads to sort of much more serious illness. And the goal is not to stop the spread, because that's very difficult to do, if not impossible. The goal is to slow the spread so that we give time to our hospital system to be able to adapt and be able to take care of everyone who gets sick and needs hospitalization. The more we slow the virus, the better outcomes people will have, because our hospitals will be more prepared. So that's the goal. So, you know, I think, you know, we can anticipate, as the governor said, that a majority of New Yorkers will become infected. And we just want this to happen in as slow a way as possible, because then people will be able to get better, you know, more frequently. Based on what we know today, and these numbers were from the governor's Saturday press conference, about 14% of people who get infected need to be in the hospital, and about 4% go to the ICU, the intensive care unit, the part of the hospital where these famous ventilators are used. The death rate is about 1% so far. Now, the actual numbers are probably lower than what I've said because we're not testing the general population. We're mostly testing people who are sick. So these numbers don't include the people who get infected and never develop symptoms. So, the 14%, the 4%, the 1%, this is probably high. These numbers are probably higher than the reality. So for the most part, people recover. And most people who get this will be okay. However, we are in a very scary period. The infection rate, the number of people who get sick will look worse and worse for a few weeks, but we are going to get through this. Just to make sure that everyone understands that most people who do go to the hospital everyone who goes to the hospital with this illness and recover are often discharged, not when they're absolutely symptom-free, but when they no longer need those hospital beds. So we create space in the hospitals for people who are sicker. So most people who are discharged from the hospital with COVID still have some symptoms and they need to finish getting better at home. And as Moira said, we have this national shortage of medical supplies, which the state is sort of desperately trying to address and make sure that all the frontline staff in the hospitals, in the residential programs, in the outpatient programs, in nursing homes, everywhere, have access to the supplies they need to keep clients and staff safe. But this national shortage has been a very painful reality, and there's a lot of news stories about that. We can move to the next slide. So just to review, the symptoms, the most common symptoms of COVID-19, which something to look for, are a fever of 100.4 degrees or higher. That's the fever. 38 degrees Celsius, 100.4 degrees Fahrenheit. And what we know is that it's oftentimes not continuous. It gets better and it gets worse, and it gets better and it gets worse. So that's if that's happening, that's normal. And then there's often a lot of respiratory symptoms, new cough, new sore throat, new difficulty breathing. And sometimes there's other sort of initial symptoms that in a minority of people. So for example, diarrhea or belly upset, for example, might be something that you see first. But the most common initial symptoms are fever and these respiratory symptoms. So if any of your clients or any of your staff develop these, it's very concerning. So you should keep an eye out for that. Now, the virus spreads primarily through droplets in the air. Someone coughs, someone sneezes, all that spit goes flying in the air, and it lands on someone else's face or someone's eye or someone's nose, and that's how the infection spreads. That's the primary way that the infection spreads. Another way that the infection spreads is when you touch a contaminated surface with your hand, and then you touch your own face, your own eyes, or your own nose, or your own mouth, and then the virus gets to you in that way. The virus does not go through your skin. It infects you mostly through your nose and your mouth. So frequent hand washing and keeping sort of apart, sort of physically distant from others to avoid getting coughed on or sneezed on is the most important thing. And of course, not touching your face is really important unless you've just washed your hands. If you have to scratch your eye or if you have to scratch your nose, wash your hands, then do it. Next slide. So just talking about some basics of infection control. So on the OMH guidance website, we've created a sort of really long, detailed guide for residential programs, which we hopefully will update as needed. So just keep an eye out on that. Just share that with your staff. Information changes probably faster than we can update the guidance, but we will try to keep it as updated as possible. It's really important to educate your staff and your clients about keeping 6 feet apart whenever possible, and about sort of hand hygiene and face hygiene. Hand hygiene, wash your hands all surfaces, all fingers, in between your fingers, back of your hands, your thumbs, the side of your hands, 20 seconds, soap and water. Does not have to be warm water, it can be cold water. Whatever temperature of water you want, just wash your hands 20 seconds with soap. The State Department of Health has some awesome posters on how to do this. It's linked on the guidance that I just mentioned. You can click on that link and it's available in a whole bunch of languages. To the extent that you can, and especially if you are in a hard-hit area, which we in New York City, all of us are in now, don't allow visitors to come into your programs unless it's critical for a client's health and well-being. If anyone has any symptoms, coughing, fever, definitely don't let them in. You don't want these folks, potentially contaminating your staff or your clients. And it's really hard, right? Because there's all sorts of reasons why people would want to visit. And it's important that the clients understand to the best that they can that we need to keep folks apart. Increase the disinfection of frequently touched surfaces, tables, doorknobs, light switches, toilets, the toilet flush handle thingy, sinks, you name it, phones, telephones, just wipe those down as much as possible. You can use whatever you've been using to clean surfaces until now, just do it more frequently, at least daily. Everyone should be wiping down their phones at least daily. To connect with your clients' providers, use telemedicine. The whole OMH outpatient mental health system is transforming into becoming a telemental health experts. Different clinics are having more success than others, but try to connect with them via telemedicine. Tell your clients and your staff to report any symptoms as soon as possible. Even if it's minor, so that someone can think about, is this a COVID symptom or not? And if you have shared bedrooms, try to keep the beds 6 feet apart and try to have head-to-toe sleeping arrangements to maximize the distance between people's mouths. Next slide. Okay, so talking a little bit about staff, and the thing that's so hard about this is that this information is changing all the time. So what I'm about to say is more recent than what is in our written guidance, and hopefully we can update that soon. Okay, so if a staff member has COVID-19 symptoms or tests positive, they should stay home. We want to distribute information about when they can come back to work, but it's continuously changing, and we will do that on the website, so just keep an eye. If a staff member has direct and extended contact with someone who has COVID-19 symptoms or tested positive, then that staff person can continue to come to work, provided they wear a mask if it's available, and they should check their temperature every 12 hours. If they develop a fever or any other COVID symptoms, they should go home. They have to go home. If no mask is available, then that staff person should stay home for 14 days after the last exposure. Now, a contact of a contact doesn't have to do this. It's just a direct and extended contact. So if you sit in a room with someone who has tested positive or has symptoms for several hours, right, that's a direct and extended contact. If you get a delivery from someone who is sick, that is not a direct and extended contact. That's okay. Now, the staff members should also try to protect their families, while this is happening. So, to the degree possible, they have to maintain 6 feet away from their families so that their families don't get sick. This is very difficult. My husband is a doctor in an emergency room. He has had extended contact. We live in a New York City apartment. To keep 6 feet away is very difficult, but we're doing the best we can, and it's and staff members should be sort of instructed to keep that in mind. Next slide. It's really important that all programs, from state psychiatric centers all the way to outpatient clinics, continue to accept new patients, new referrals, because the more room we make in hospitals, the more we decompress the general hospitals, the better it'll be for everyone. Now, residential programs should request an attestation or some sort of communication from the referring source that the client has not had any new COVID symptoms. Unfortunately, because of the limitation and the availability of testing, we can't request a negative test for admission. And that's just the way it is because of the availability of testing. If possible, any new client should have their own room. Any new client should stay 6 feet away from all others as much as possible for the first 14 days. And if available, the new client should wear a mask for the first 14 days. If not available, then keeping 6 feet away from others, is sufficient for droplet precautions. If they are coughing, that is even more important for them to sort of stay away from folks. Next slide. Okay, so what do you do, when a client develops symptoms? When I wrote this slide, I wrote if, but it should really be when. So symptomatic clients should be asked to stay in the room, ideally to a single room. If possible, exposed roommates should also have their own room for 14 days. If they remain symptom-free after that, they can share a room with someone else. The symptomatic client should take meals in the room, and if possible, if they are available, the client should wear a mask. Programs should immediately contact the local health department, which in New York City is the Department of Health and Mental Hygiene, for information on testing, and local health departments may have provisions for alternative housing arrangements. That's going to depend on a location-by-location basis. Most cases of people who get infected will not need a hospital. So a hospital is only necessary if someone is really, really sick or is having breathing difficulties. You should always call the hospital ahead before sending someone. If the person looks like that they're more sick than what a bad flu would look like, it's okay to refer to a hospital. And then they can make the decision whether or not the person needs hospitalization or not. If you can always, call ahead and sort of get a sense of what the lay of the land is in the hospital to see, if they have the capacity to accept someone. If more than one client is positive, these two positive individuals can share a bedroom and talk to the outpatient providers to get nicotine replacement therapy to eliminate nicotine withdrawal in these folks. We don't want them walking back and forth, inside, outside, sort of coughing, throughout the space to get a cigarette. I mean, they might not be able to quit, but the more that they can reduce how many cigarettes they're smoking, the less exposed everyone else will be. So put a patch on them, give them gum, give them lozenges, inhalers, nasal sprays, whatever they want to help them not have to go get that cigarette, and use it liberally. Next slide. When a client develops symptoms in the residence, other clients age 50 or more who have sort of medical or respiratory problems or who smoke should also wear masks if they're available. If they're not available, then these folks should definitely stay always at least 6 feet away from the individual who is sick. And these folks should significantly increase their hand hygiene. If available, staff should wear masks and increase hand hygiene. If no masks, staff should try to stay as far away as possible, 6 feet at least, from these individuals as much as possible. Try to increase the sort of cleaning of the surfaces. If there are several bathroom facilities in the residence, set one aside for people with symptoms or who tested positive. And sort of sanitize the surfaces after each use. Leave the windows open to sort of help clear those droplets from that steam. If there's only one bathroom in the facility, it's critical to disinfect. So leave the fans on, leave the windows open. After the individual with symptom showers, sort of make sure that all the steam is cleared out. before the next resident uses that facility. Unless the person is showering, the individual with symptoms should try to use a mask. Between the individuals who are not sick, try to stagger shower times. Leave fans running at least 20 minutes between showers. Sort of leave the window open as much as possible. I know upstate it's still really cold, but here in the city, spring is coming, and things will warm up. So if you have windows in the bathrooms, try to leave them open. Obviously, clients with symptoms should not use shared spaces. So programs that have to change existing routines to accommodate that. So for example, snacks and so forth. These questions need to be figured out. Next slide. Okay, so oftentimes our clients do go to the hospital for medical or psychiatric admissions, and when they return, they might have been exposed to the virus, even if they didn't go to the hospital because of COVID-19. And people who do go to the hospital with COVID-19 often come back, as I said, with some symptoms still. So a lot of times these individuals are going to be really anxious, really scared. Try to ease their fears, remind them that most people who get this get better, and any sort of people who return from the hospital without symptoms, treat them as a new client. Try to keep them, sort of more distant from everyone else for the first 14 days. Folks who come back, because of hospitalization for COVID-19, make sure that you use the same precautions you would for the individuals who are sick in the residence. Next slide. Okay, I know I've been going really fast. We'll have happy to take questions in the Q&A time to clarify anything. Just a quick word about scattered site housing programs. So again, make sure that you educate the clients about they shouldn't be socializing indoors with others, to restrict visitors, to practice hand hygiene, not to touch their faces, some basic disinfecting techniques for their sort of surfaces, phones, whatever. And when outside, out and about, to keep 6 feet away from everyone else in public when they're in the park or walking around the street and so forth. It needs to be a case-by-case decision whether to continue visiting clients. So obviously the reasons to continue is if the client needs a visit for sort of the basic survival, access to meds, food, basic supplies, or if visiting will keep them from getting disengaged, or we definitely want to reduce the risk of hospitalization during this time. So that's a case-by-case, client-by-client decision. You can use telephonic or video visits to replace face-to-face visits if that's possible. And before entering a client's home, staff should wash their hands or use an alcohol-based sanitizer and wear a mask if available. If no mask is available, try to maintain, as always, 6 feet distance from the client to avoid getting coughed on or coughing on the client, and so forth. So I know I gave a lot of information. I'm happy to answer any questions during the Q&A period. I now want to pass on the baton to Brett Hebner, who is OMH's Director of Housing.
Thank you, Dr. Kasoy. Good afternoon, everyone. Just want to reiterate real quick our sincere thanks and admiration for all of your efforts, our shared concern for your staff and your residents, and just to be assured that OMH is working very hard to support your agencies during this time. I'm going to review some issues that have been brought to our attention by providers, and the first is a rather obvious one, but we want to be perfectly clear about the executive order, kind of known as the stay-at-home order that identifies essential versus non-essential services. It clearly includes agencies that provide service to individuals with mental illness that are operated, licensed, designated, funded, or authorized by OMH. as essential, and this includes administrative offices and those employees necessary to support the essential functions of your agency's mission. So we wanted to be crystal clear about that. We understand that billing and administrative functions are critical, and that executive order certainly covers your entire agency. However, providers' leadership should use their judgment on how to balance achieving the reduced close contact in offices while maintaining operations. For those folks who are able to perform those critical functions remotely, they should be doing so. Next slide, please. Just to reiterate something that Dr. Kasoy indicated, we're asking that wherever possible, housing providers continue to allow admissions, to allow step down from inpatient psychiatric hospitals and CPAPs. Again, the goal being to allow hospitals to free up beds for those needing those beds to treat individuals suffering from COVID-19. Understanding that may be difficult at certain times. We understand the staffing challenges that you're facing. If providers anticipate that or experience an interruption of program operations or are modifying program operations to ensure continuity of care, we'll talk about that more in a moment, they should definitely notify their OMH field office and the LGU. Next, please. So this slide was put in there under the assumption that we did not have good news that Moira shared. So I think we can skip over that. We're going to put out guidance on this staffing issue hopefully later today, and we did finally get good news on that this morning to allow with an executive order allowing folks to be able to who are previously screened to be able to work in your other programs and in other agencies. Next slide, please. Okay, so again, we recognize that you're facing extraordinary staffing challenges, and we would consider proposals or modification of staffing patterns to ensure basic needs of individuals and their service needs are met. So to the extent that providers wish to propose any kind of programmatic modifications they deem necessary, please submit a brief description to the appropriate field office. And field office and central office can collaborate and will review and respond with the approval or request for more information in an expedited manner. We're really shooting for 1 business day with the understanding that we really need providers to make every reasonable effort to ensure resident health and safety, the provision of basic necessities, food, medication, etc. Next slide, please. Similarly, if you did not have the opportunity to tune into or review the slides from Amos Lane, our CFO's presentation on Thursday, OMH is allowing providers flexibility in terms of contract resources, in terms of occupancy standards, or flexibility between budget categories, etc. Providers should submit those requests also to their field office or local government unit. Direct contractor LGU request should essentially just include the purpose, type of flexibility needed, and the relation of that request to the COVID-19 response. And again, field office and central office will review and respond, hopefully within 1 business day. Next, please. Another issue that was raised is around the ability of providers to use vacant units or temporary arrangements, and so we want to encourage folks that you know your programs best, and we would be willing to look at that flexibility. We would again ask you to kind of put it in writing to us, but providers can certainly make use of vacancies wherever possible to help isolate if that's an option for you, and temporary arrangements to promote quarantine or isolation may be acceptable, provided that those areas that were not used for sleeping are finished, do have emergency egress, light and heat, ventilation, smoke detection. We don't want to substitute sacrifice one element of safety to achieve another. So next slide, please. And so I think I'm going to turn this over to Moira, and I'm not sure if the host wants to give us some feedback or some advice on how to use the chat box, but we just want to point you, before I do turn it over to Moira for the Q&A, I just want to point you again to our centralized location for all of our guidance documents there, and updating and trying to provide as much as possible information for you to handle the many challenges that you're facing. Moira?
Thank you very much. And Boris, you're going to guide us in our Q&As.
Yes, I will. And I wanted to say thank you to all the presenters today. And we'll jump right into the Q&A portion. As mentioned, we'll try to address as many questions as possible in the time allotted, and also if OMH might need to take some of the questions back before they are able to answer them today. So jumping right in, first question we got was, Moira, was about your initial comment, and when you were referring specifically to the guidance about fingerprinting and background checks. So it's just, can you clarify a little bit more about that?
Certainly. Basically, we got an executive order this morning regarding fingerprinting and background checks and some flexibility around that. Our attorneys are meeting as we speak right now and working on putting out guidance that you will receive later today.
Excellent. Thank you. Next question. It's about potentially some clients that might call JC if there are limited visitors. And so I guess the request is it possible for JC not to investigate these calls or these cases when clients are, I guess, complaining about visitor limitation?
We've been working very closely with the Justice Center, and they are very much in tune to the challenges that everyone is facing with COVID-19. As I just mentioned, our Executive Deputy Commissioner is on in communication with them on a daily basis. With the Justice Center, they will look at everything through the eyes of the fact that we have guidance, we have expected flexibility, and we have given guidance for some limitations. So as I said, we're working with them, we're working hand in glove with them, and we will continue to do so.
Excellent, thank you for that. Next question, I think it's question, comment, the way at least I'm reading it. It's more about communications that providers can expect from OMH, HHC, DOH, and so forth. Unfortunately, it seems like this particular provider recently had a loss of a resident to the pandemic and were not notified by a hospital. There was also a clinic who seemed to close because their psychiatrist tested positive, but again, they had no outreach or notification from that clinic. So I guess the request here, is there a way that the state or city or others could also communicate some of this to the provider or increase the communication? So any thoughts on that?
Yes. I was involved in the communication with that agency, which I was happy to help, and so was our field office. We are going to share with our clinics that they need to be as communicative as possible. If there is any challenge with not getting information, please call the city field office or call our office here or email Brett or myself or Donna, and we will follow up for you.
Excellent. Thank you. Next question. Should mandatory fire drills continue at this time, especially if clients exhibit symptoms?
You know what? I think we'd have to talk to our licensing folks with that. We'll get back to folks on that.
Okay, got it. What about the preliminary and final 595 notices? Should that be placed on hold?
I think let me get back to folks on that as well. Placed on hold. Okay. All right.
Okay. Got it. Thank you. There's also a comment and I guess a question about, if the clients are refusing to self-isolate or, want to make sure that others don't know that they have tested positive and are calling it HIPAA issues and other types of things related to kind of that type of a situation? Any advice on how to handle that types of situations?
Flavio, Dr. Kasoy, could you take that question, please?
Sure. I mean, I think this is a real challenge, right? If folks are, refusing to do what needs to be done to keep themselves and other people safe. I mean, I think what I would advise is that since every situation is different, to get in touch with the providers for helping take care of these individuals to see if there can be something done to address the root cause of why they might be not adhering. Is it that they're sort of delusional and paranoid, and they're sort of at baseline and not able to take the information in, or is it because they are sort of craving and wanting to smoke, and what can be done about that? But I think this needs to be done, sort of taken care of in a case-by-case situation, and we know that sometimes our folks can be really difficult because of a lot of things that happen in their lives and so forth. So my recommendation is to connect with the outpatient provider, and to the degree possible, get all the other sort of clients to respond, as much as they can. So if available, people should wear masks, sort of, try to up your disinfection, and sort of have group meetings about this. If clients can't take information from the staff, maybe they can take it better from some of their peers. But this is very difficult. If folks are doing things that are sort of seem to be a significant danger to themselves, danger to others, then I think there has to be a real consideration of what can be done, and the outpatient sort of team that's sort of working with the residential programs to take care of them, should help weigh in on that.
Great, thank you for that. Next question about new admissions. So the question is, if congregate sites have multiple clients with positive symptoms, should they still be allowing new admissions?
Dr. Kasoy, in that case, would we agree that they should slow their admissions at that point and really focus on the quarantining those individuals?
Can you repeat the question, just to make sure that I understood it correctly?
Yeah, the question was, if congregate sites have multiple clients with positive symptoms, should they still be allowing new admissions?
Yeah, I agree with Moira. I mean, I think it needs to be a risk-benefit decision. Do we want to take in people who are asymptomatic and potentially put them at risk? Probably not. At the same time, we're going to get to a point where there's going to be extensive community spread, and I think we have to balance, the overall capacity of the system to take care of everyone with the needs of the individual. I think in this situation, we might have to look at it a case-by-case situation. It's hard to predict, but if possible, slowing down admissions makes sense. But if the system is overwhelmed and we need to decompress the system, I think we all move to emergency basis. And I think this is a really difficult ethical quandary.
Mm-hmm.
Yeah. No, understood. Thank you.
We're all, I think as you are on the ground, kind of making decisions as you move forward, minute to minute, hour to hour, and day to day, we are also looking at things like we have never looked at them before. So your partnership with us, your feedback from us is very, very important. I just want to add that, we are in contact with your advocacy organizations such as CHINI and ACL, and we're going to continue to have conversations with them and really make sure we don't lose touch with what you're experiencing and what your needs are.
Excellent. Thank you. Next question, can we consider OMH wraparound funds to use nursing services to care for residents who are self-quarantined with positive tests and or symptoms in order to keep folks at home, of course, and out of the hospital?
I would say that any reasonable cost tied to the COVID-19 virus that needs to be put in place for the safety of the individuals needs to be documented and would probably be able to be utilized. Again, it's a case by case. I would shoot an email to your field office and we will authorize it if we can. And so far, the request people have presented, although there has not been many, we have authorized. So I would say if you have a plan, you have an idea, send it to your field office, send it to us.
Excellent. Thank you. The next two I have are targeted for the children residential. So the first one is the for co-located OMH and OCFS children providers in addition to commingling youth. Can we commingle staff to safely meet staffing needs?
Yeah, thanks, Boris. So that's in the mix of what we'll be talking about with council and licensing. Stay tuned on that. I don't have an answer for you now, but it's a good question and one we're already creating answers for. So more guidance will be forthcoming on that.
Excellent, thank you. Another question on the children's residential side. Can RTFs minimize the presence of physicians who are at very high risk of COVID exposure, and can they use telehealth to authorize, for example, restraints?
So that guidance has been issued, and my understanding is that it's CMS federal guidelines that will not allow for the use of telepsychiatry in that regard. And I hear you about the challenges about doc time, but you know, we need to just do the best that we can. There has been on the we did send out guidance that's equivalent to what was sent out on the adult side that allows for nurse practitioner and physician's assistants to be of assistance to doctors. But we can only adhere to what the federal guidelines allow us.
Can I take a stab at that also?
Yes.
Okay, so this is a big challenge, and it really is the federal rule that prevents us from sort of easing anymore. One thing that we said on the adult side is if the psychiatrist is working remotely or covering multiple sites, or sick and working from home or whatnot, depending on the site. As long as there's a nurse practitioner or physician assistant on site, there can be a collaboration between the psychiatrist and the advanced practice practitioner to be able to do restraints and seclusions in some settings. But this, it's really difficult to make it any sort of more flexible because of the federal rules. I think please keep us posted on how that looks and how that works for you, because we really wrestled with this. We spent a lot of time trying to figure this out.
Understood. Thank you. Thank you for that additional information. So we have a couple of requests or questions about the slides in this presentation. And again, just a reminder to everybody, we are recording this and we'll be posting this, both the slide deck and the recording of this presentation on the MIGTAC website, hopefully within 24 to 48 hours. So stay tuned for that, and we will be making sure that everybody who joins and others will be notified when it's available. Excuse me. Next question is about food shortage. So the question is, food shortage and residents who spend all of their money buying takeout, which can be quite expensive, but are now short of funds for the rest of the month. Any suggestion or how can, I guess, providers, programs help with that, or the state can help with that?
Again, I would ask the agencies who are struggling with that specifically contact their field office, and we can share that with our CFO to see what kind of flexibility we have to respond to that need.
Got it. Thank you. There's a question about if a staff person is diagnosed or has positive COVID, is there communication that should be given to residents and or families about that situation?
Dr. Kasoy, do we have a process for that or guidance on that?
We
or
don't.
Or should we get back to folks on that?
That's a good question, and we'll get back to folks on that.
Yep.
Excellent. Thank you. Question about budget advances and how to code COVID expenses. Also, you know, that's something that should be written up and sent to the field office as folks do get the expenses.
Boris, can you repeat that question? I'm not clear what the beginning of it was. I'm sorry.
No, that's okay. Will there be a budget advances and how to code COVID expenses? That's one. And then is that to be written up and sent to the field office?
I will talk to our CFO here and ask what the directives are on that, and we will share that in the Q&A. The FAQ, I should.
The FAQ, got it. Thank you. We do have a couple of questions, which I suspect we would need to get back. Of course, people are anxious about getting PPE, so want to know a little bit more about timeframes or any additional information. I don't know if you have anything besides what was already stated.
I don't. You know, there's a shortage nationally. Certainly, we all know that. We have been working here to see if we can access some directly, and we are trying to bundle a request. And you know, we've put that request in, and we will know within the next couple of days what the outcome of that is. And we will let you know as soon as we can. And, you know, we looked at this, in putting this together yesterday, we looked at it from a statewide lens. So, you know, I don't know how much we're going to get, but we put in a request for a significant amount, and we will let you know as soon as we can. We recognize it's a need.
Understood. Thank you. So just being mindful of time, we probably have maybe a couple more questions. A question on billing Medicaid. So will guidance be forthcoming about flexibility in billing Medicaid in light of the recent approved CMS waiver?
Yes, it will, and we are working with the Department of Health and CMS. So again, we will respond specifically to that in the FAQs, and any new information we have will be sent out.
Okay, thank you. Just quickly looking through, because we have a couple of repeats. Just want to make sure that I get as many questions that we haven't addressed yet. So I guess there's a question about billing shortfalls potentially, and if there's any information on potential deficit funding to make up for that shortfall.
Amos Blaine, our CFO, did a webinar, I think it was last week, specific to state aid and deficit funding. I would ask that folks take a look at that. That's on your website, MCTAC. But also, if there's a specific question, we can put it in our FAQ.
Excellent.
And
Thank you.
as far as I know, also off of that webinar, there were a number of questions, and Emil has put together some responses to them and is continuing to do so.
Excellent. Thank you. I think with that, just again, being mindful of everybody's time and so forth, again, wanted to remind folks we have recorded this. We'll be posting both the slides and the presentation. I do want to again thank OMH presenters for this information and for everybody else for joining. And again, just want to echo what was said throughout the presentation for the providers on this phone call. Thank you for everything you do. So if there's any last words, Moira or anybody else, before we close the session today?
Just our sincerest thank you. And, you know, we promise you that we will continue to work to help you in the ways that we can. Feel free to reach out to your field office, to reach out to our offices here, and continue our partnership together. Thank you.
Excellent. Thank you, everybody. Take care.